slide visible to all of you?
Yes, yes.
Okay, thank you so much. So today I'll be speaking on Dr. Sahus 2mm MSICS incision with back cuts, and I'll be using I'll be showing a video on PMMA IOL implantation in this case. So my gratitude to Dr. Sahu for teaching me this technique and my mentor Dr. Harsha sir. So the resultant high wound strength of the MSICS technique has actually enabled us to modify the incision parameters. So this has also in turn helped us to minimize our surgical in-this astigmatism and improve the refractive results of the surgery. It's not moving. 1 second, it's not moving. My slide is not moving. So these are some of the instruments that we have been using for this technique. And I'm going to show a video here. So this is a 2mm incision that I have placed 1.5mm behind the limbus. And I'll be placing the back cuts on either sides of the incision. Now here we need to understand that the scleral pockets that I'll be creating here will be around 2.5mm behind the main incision, and the scleral pockets has to be on the same plane. The reason being that if this plane is not maintained, as these are back cuts, we will have difficulty in the wound architecture later on. So here I have introduced a vectis and fragmented the nucleus in the anterior chamber using the visco cannula by continuously irrigating the visco. So you can see by creating a pocket of around 4mm with the back cuts, we have actually been able to implant a 5.5mm optic. So I am making it a point that we are using a 5.5mm optic here. So these are some, this is one of our article that was published considering the early post-operative astigmatism. So when we try to compare it with 2mm and 6mm MSICS technique, we found out that the mean spherical equivalent of the autograph measured astigmatic error was changed by only 1.14 diopter cylinder when the axis was ignored. Now we will look at the next patient where you will see that when the axis was not ignored, that is when you look at a regular astigmatism of 0.76 diopters at 164 or 170 degrees, you will see that you are inducing an astigmatism of only 0.75 and thereby giving the patient a zero astigmatic post-operatively. So when we compare the endothelial cell counts, these are also significantly comparable with 6mm MSICS, and it is definitely better. But while comparing with the phaco, we see that although these are not significant, but we do have a comparable result considering the endothelial cell count. However, as I have already told you, when we ignore the axis, we are actually inducing a 0.75 cylinder. So therefore, in comparison to the phaco, this also creates a lesser astigmatic neutrality if you are placing the incision at the steeper meridian. So the wound integrity can be seen in either by using an UVM or by ASOCT. So you see that the wound integrity is definitely tough, and there is and the ocular surface remains stable post-operatively. However, this technique being an advanced technique, we felt that the learning curve was difficult. And since I had learned this technique from Sahus sir, I had some difficulty with the technique. And there was an point where where I had a de-roofing of one of the patients in the main tunnel, and corneal edema being one of the most common complications in my hands. Now, why did this happen? This happened because when we are not putting the back cuts before doing this phaco-fragmentation, what we are actually doing is that we are actually increasing the diameter of the 2mm, and this does not do justice to the incision size. So we need to put the back incisions in order to create the scleral pocket tunnels. Otherwise, there is no compressible bed which won't be created, and thereby when we are bringing in the fragments of the nucleus, we are actually creating a purse string effect and causing a distortion of the wound architecture. So the wound ergonomics remains that if you want to put an PMMA IOL through a 2mm incision, the main incision remains 2mm with a back cut of 2.5mm or 2mm behind, so that you can create a diagonal tunnel or a hypotenuse of around 3.9mm, so that you can introduce a 5.5mm PMMA optic, wherein the scleral pockets actually give you the elasticity to put in the IOL on either side. But the main incision in the cornea should extend up to 6 millimeters so that you can easily implant your IOL. So this technique is not only a refinement of the incision, but also creates an astigmatic neutrality when you are considering the steeper axis. Viscofragmentation should always be done because otherwise there is harm to the corneal endothelium. And to have a good corneal endothelial cell count, it is important that the visco should be continuously irrigated while fragmenting the nucleus in the AC. Or else you can also move ahead with the Khan's chopper and bisect the nucleus in the bag. We all know that foldable IOL is relatively easy to implant through a 2 millimeter incision. However, if you want to implant a rigid IOL, 5.5 millimeter optic is desirable, and the incision backcut should extend to up to 2 to 2.5 millimeter. It is definitely cost effective and eco in terms of community services and causes a less carbon footprint. So the results are absolutely gratifying for the patients, and we have seen that these are comparable to other surgical techniques like your phaco as well. What I want to end by saying is that creativity is seeing the same thing but thinking differently, as said by late APJ Abdul Kalam sir. And these are my references, and thank you for your patient hearing.